Hello, good evening all.
Good evening,
Am
ma'am.
I audible clearly?
Yes, ma'am. Very nice.
So happy Akshay Tritiya to all, happy Eid and also Parashuram Jayanti. Good evening, and I invite all the participants to this wonderful webinar today, which will be held about CA esophagus, which is more prevalent in the northeastern region of our country. And as the statistics say, that India has an age standard incidence rate of 6.5 per 100,000 populations for male and 4.2 per 100,000 population for females. And this translates to approximately 47,000 new cases of CA esophagus per year and around 42,000 reported deaths. So such a very high incidence of esophageal cancers, dying so much, mostly it's because they are diagnosed in the later stages. Light dysphagia and acidity is overlooked unless and until it goes into obstruction and stenosis, scarring, etc., and metastasis. Squamous cell carcinoma of esophagus is most often common in the upper and the middle portions of the esophagus, and it attacks mostly the men around 45 to 70 years of age. And they are more 3 to 4 times more likely to be attacked because of the bad habits of smoking, drinking, and little bit you can also blame the esophageal acid reflux for it. So for this wonderful webinar, we have an expert, eminent orator, who is the chief consultant, senior consultant in Rajiv Gandhi Cancer Institute, Delhi. She is our old friend and she has been to Gorakhpur also many times. And this webinar we are holding with Dr. Chaturvedi Cancer Hospital and Research Center Private Limited in association with the members of Oncology Integrated Society. And the wonderful speaker, Dr. Swaroopa Mitra, for whose introduction will be given by Dr. A.K. Chaturvedi, the owner of Chaturvedi Cancer Hospital, Gorakhpur. Yes, over to you, Dr. Chaturvedi.
Thank you, Dr. Deepti. Am I audible? Thank
Yes,
you,
sir.
Dr. Deepti. As you know, today's topic is very important. And carcinoma esophagus is a very important disease. And for that, we have invited Dr. Swaroopa Mitra, which is very well-known national and international identity. And she is a senior consultant and chief in gynec and genitourinary radiation oncology department of Rajiv Gandhi Cancer Institute, Delhi. She is a very good orator. She is a very good writer. She is a very good teacher, and she has got many qualities. I name a few. She has vast teaching experience. She was invited as faculty at various national and international forums, American Society of Oncology, ICRO. She was examiner in Guru Govind University, Delhi for the BSc Radiation Technologist and DNB for postgraduate degree in radiation oncology. She has carried out many research projects in oncology. Some of them are the principal investigator with ICMR. She has many papers in publication, and she was also reviewed, written many papers and reviewed data. She has over 75% research papers. She has been thesis co-guide and guide for the postgraduate oncology students and mentor to the national and international oncology students in teaching programs by UICC. She is the co-guide for PhD thesis at the University of Ghent Belgium, 2022. She was invited as faculty at ESCO, and she was to impart oncology education and training to the Asian countries like Nepal, Azerbaijan, Bangladesh, Pakistan. Social and public forum. She had been a part of the team to start IGRT technology in New Delhi. She had played a key role in establishing the Rural Cancer Center at Mirpur in Haryana in 2005. Have been conducted awareness program for cancer regularly and passionately in public platforms, on TV channels, social medias, including live interactive session on Facebook and YouTube once per week. Have conducted successful training programs for registered medical practitioners, which is very important, in the peripheral parts of Haryana, Rajasthan, imparting them knowledge about early cancer diagnosis and early referral. That is very important, and we should also do such type of programs, because that will bring so many cancers in early stages, and we will be able to treat them at the early stage. Few recent recognitions are nominated member of Project Advisory Committee for the Health Communication Department of Science and Technology, Government of India, 2014 to 2017. Selected amongst Women Achievers of the Year by Hindustan Times in 2015. Receives oration at the Endo-Oncology Summit held in January 2018. Featured in the first ever film made on the COVID vaccine for public awareness, which was released on an international platform in 2021. She received certificate of recognition by the Health Minister Jharkhand in May 21 for the contribution in creating cervical cancer awareness in women of Jharkhand. She had been felicitated as a guest of honor Amrit Mahotsav celebration in May 22 at the Mount Abu by Spiritual Application Research Center, a research wing of Raj Yoga Education and Research Foundation, Prajapati Brahma Kumari, Ishwariya Vishwavidyalaya. Have been recognized as motivator for the woman empowerment by News India in 2022. Received awards of excellence in oncology by the Delhi Medical Association, November 2022. So many credentials at his credits and so many experience. I invite Dr. Swaroopa Mitra for your presentation on the carcinoma esophagus. Dr. Swaroopa Mitra.
Thank you, sir. Thank you, sir, for that elaborate introduction. Had I known, sir, that you would...
Voice is...
Oh, okay. Can you hear me?
Okay.
Am I audible?
Okay. Yeah, now it's okay.
Had I known, sir, you would read out the entire thing, I would have just written 2 sentences. Thanks so much,
No,
sir.
you have given me, so it's a very nice thing, and you got so many achievements. So I'm feeling proud of reading out all these your achievements.
Thank you, sir. It is such a pleasure, such an honor to be here, sir. And every time you give me this opportunity, I feel so blessed. So, ma'am and sir, thank you so much. And today I'm about to talk about carcinoma esophagus. And I have, as ma'am had told me, to make it simple for non-oncology doctor friends. So I'm not introducing too much of a technical part of the radiation per se. So ma'am has spoken about cancer esophagus. So briefly, esophageal cancer is a disease in epidemiological transition, actually. In 1970s and earlier, squamous cell carcinoma used to be the most common type of esophageal cancer, the risk factors being smoking and alcohol. But nowadays, there is a very steep increase in the incidence of esophageal adenocarcinomas. And in fact, I feel not only esophageal adenocarcinomas, even cervical adenocarcinomas have started increasing. So there must be something going on in the environment. So for adenocarcinomas, most common predisposing factor has been found is the GERD, or the gastroesophageal reflux disease. So briefly, the carcinoma esophagus anatomy, we all know it is just a brushing of our memories. The esophagus is a 25 centimeter long muscular tube. It starts from the lower end of the cricoid cartilage, that is at the level of C6 vertebra, and it ends into the cardiac orifice of the stomach at T11 vertebra. It has been divided into three parts: the cervical part, the thoracic part, and the abdominal part. The cervical part is right from the beginning, that is from the C6 vertebra to the thoracic inlet, that is the suprasternal notch, that is 18 centimeter from the incisors. I am mentioning these because these are very important as oncologists for surgeons, medical oncologists, or radiation oncologists. So the thoracic part has been again divided into three parts: the upper thoracic, the mid thoracic, and the lower thoracic. The upper thoracic, it starts from the thoracic inlet, that is where the cervical esophagus ends, that is the suprasternal notch, and it goes up to 18 to 23 centimeter from the incisors and ends into the level of the tracheal bifurcation. And at this level, the mid-thoracic esophagus starts, which is about 24 to 32 centimeter from the incisors, and this ends midway between the GE junction to the mid-thoracic esophagus. This is at this level. And then starts the lower thoracic esophagus, which ends along with the abdominal esophagus, that is at the cardiac orifice, and that is totally, it is 32 to 40 centimeter from the incisors. So this is how the esophagus has been divided. Now, talking of esophageal cancer, what are the commonest symptoms? So there are many symptoms. Like all cancers, there may not be any symptoms initially, and when the patient actually presents with the symptoms, it may be a little late or advanced. But basically, dysphagia, it is the commonest symptom, initially for solids, and gradually it progresses to include liquids also. And it generally occurs when the esophageal lumen is less than 13 millimeter. And with dysphagia comes weight loss. So severe, distinct weight loss should not be neglected. They have to be, many times the patient does not complain of dysphagia, but he comes only with weight loss. So even then, we have to ask the patient about the history of dysphagia. So when we ask him, so maybe he can come out with the complaint of dysphagia. There can be sometimes bleeding, oral bleeding. There can be epigastric and retrosternal pain. This is also quite common, but many times the patient has to be asked. The leading questions have to be given to him before he complains about these features. Hoarseness of voice due to the involvement of the recurrent laryngeal nerve. Intractable coughing or frequent pneumonia. These are actually quite severe symptoms. These are alarm bells because a tracheobronchial fistula may be the underlying factor. In case of metastatic disease, there can be bony pain and abdominal distension, anything related to the site of the metastasis. So basically, dysphagia, weight loss, epigastric, retrosternal pain, hoarseness, and sometimes bleeding through mouth. Now, what are the causes? Yes, there are genetic factors like most of the cancers these days. Alcohol and cigarette smoking, they are closely related to esophageal cancers, as like many head neck cancers and other cancers. Nutrition, iron, riboflavin, vitamin A deficiencies, generally the esophageal squamous cell carcinomas, they are a disease of low socioeconomic group. So socioeconomic status is also an underlying cause for esophageal cancer. And this also indirectly gives the nutritional deficiencies. There are some uncommon exposures and diseases like the achalasia cardias, radiation, exposure to the esophagus, pickled vegetables, iron deficiency, anemia, dysphagia, celiac disease. They have been related to esophageal cancers. Barrett's esophagus, This is a specialized intestinal type of metaplasia in the tubular esophagus. It is a well-established risk factor for adenocarcinoma esophagus. And so is bile refluxes and gastroesophageal reflux disease, that is GERD. So these are the common causes seen in esophageal carcinoma. So how does it cause all these events, there's a cascade of events actually, right? From gastroesophageal reflux, just like ma'am was saying, gastroesophageal reflux is a very, very important symptom, and more of awareness is needed for, especially for adenocarcinomas. So gastroesophageal reflux, over time, it gives rise to metaplasia, and that gives rise to low-grade dysplasia, and then high-grade dysplasia, and that gives rise to adenocarcinoma of the esophagus. So a small slide about Barrett's esophagus. So you can see this, how Barrett's esophagus is. It is, what is this? This is a replacement of the normal squamous epithelium of the mucosa with goblet cells and a villiform surface configuration that resembles intestinal mucosa. And the risk of adenocarcinomas in such Barrett's esophagus is about 30 to 45 times than the normal population. So you can understand how much risky a Barrett's esophagus is. And this esophageal cancer is again 3 times higher in white men than black men. Male to female ratio is 7.6 in white and 14 in black. So we are somewhere probably in the middle. So this is how it looks, the endoscopic view of adenocarcinoma, early adenocarcinoma in a Barrett's esophagus. So how do we diagnose? So of course, laboratory diagnosis like the CBC and the metabolic parameters, they have like the PDPK, LFT, the regular blood examinations. Barium swallow is a very important test. So probably we have lost touch with this barium swallow, but still in many parts of India, which are not very privileged part of India, barium swallow is important. And I personally feel it is very, very important. Upper GI endoscopy with biopsy and cytology, this has become the standard for the diagnosis of esophageal carcinoma. Without this, we probably cannot diagnose. Endoscopic ultrasonography is gaining importance, and we are gaining more and more knowledge about this diagnostic facility. CT scan of the abdomen, chest with contrast, pelvic CT scan with contrast, if clinically indicated, needs to be done for the metastatic spread for the staging of the disease. PET, wherever PET scan is available, PET scan is important again for the metastatic status of the disease. And for us radiation oncologists, it helps us in planning, contouring and planning of the esophageal radiation. Bronchoscopy. Is bronchoscopy needed or not? Many times, because in India, most of the esophageal cancers, or any cancer for that matter, come in an advanced stage. So bronchoscopy is many times required, especially if the patient is coming with a lot of cough, regurgitation. And on CT scan, if we see the tumor is just above or around the carina, it helps to exclude the invasion of the trachea or the bronchia, or if there is any fistula. So bronchoscopy is needed, and it should be done whenever the tumor is very advanced and it is above or around the carina. Siewert category staging should be done, especially for the adenocarcinomas. This is very important. Whenever a patient of esophagus comes, nutritional assessment and counseling, sometimes even PEG tube, placement of the PEG tube is very, very important. Many times with our patient load, many times we neglect this assessment, but this is very, very important. Smoking cessation, as a doctor, we have to take this responsibility to advise for cessation of smoking for patients, and not only for the patients, their family members as well, because there is something called the passive smoking. So advise, counseling, and help the patient to quit smoking. Screening for the family history. For metastatic stages, microsatellite instability, that is MSI, and the HER2 receptors of metastatic again. So these need to be done if the facilities are available. Now, this is how barium, like I said, barium is important, barium study. So how is it important? It does detect. When we were doing MD, I think we had only the barium scan, which we used to do, barium swallow. So it detects early esophageal carcinoma. Accuracy is about 70%. And how does it show? You can see it here. This is the esophageal lumen and this is the carcinoma. So it documents the stricture, that is the area of the carcinoma, the stricture length, the diameter, location, and the contour of the disease. Intraluminal filling defect and elevated carcinomas can also be seen. Loss of esophageal distensibility with or without luminal narrowing. This is also a very important documentation which can be done with a barium swallow. Now, what about our upper GI endoscopy? We cannot do without upper GI endoscopy. Yes, we can detect the esophageal tumor very well. A biopsy of any suspicious lesion, not only the tumor, but if there is some mucosal lesion which looks suspicious, that can be biopsied. The location of the tumor relative to the teeth and the esophagogastric junction is important, and that location can be determined with the help of upper GI endoscopy. Degree of obstruction. This is also very important because on this basis, we put in a Ryle's tube or put in a PEG tube. So all these information can be given by the upper GI endoscopy. Now, what is endoscopic ultrasonography? We call it as EUS. So this facility is probably not available everywhere, but very soon, I think we are very rapidly, many hospitals are getting this facility. So it allows imaging at a very close proximity. You can see it here. So this is how the esophageal carcinoma is scanning, and this below, beside this is which is termed as B. It is the corresponding EUS image. So it provides a circumferential view of the esophagus. So you can see this esophagus throughout its circumference, above and below. So in this way, it can detect small, subtle mucosal changes, which are otherwise not seen. In a CT scan, you may not be able to see a small, subtle mucosal change, and this can be seen with the help of an EUS. A typical EUS image of the esophageal wall has got 5 layers. I shall be showing it in the next slide. Esophageal cancer, it appears as dark. You can see here they're dark or hypoechoic. It can also determine the depth of invasion. This is most important. This EUS can determine the depth of invasion based on the location and the appearance of the outer tumor border. And why can we can do this? Because the tumor appears dark. So in this way we can, and when we see the depth of invasion, so obviously we can assign the stage to this tumor also. So similar thing, just to give a collaboration, maybe if you look at the rectal carcinoma, that is also a tumor where the depth of invasion is required, and there the MRI is important. But in case of esophageal carcinoma, MRI is not so important. It does not give us so much of information as the EUS gives us. Now, when we talk of endoscopy, so let us just add a slide about endoscopic resection. We are going to talk about it later again. So endoscopic resection, it provides an accurate assessment of the depth of invasion, just as I said, degree of differentiation, and the presence of lymphovascular invasion and nodes also. So this endoscopic resection, this can be both diagnostic and therapeutic. So diagnostic, why? Because just as I said, it provides an accurate staging of early stage cancer. Let me be very careful over here. It is not for all cancers, it's not needed, but it is for very early stage cancers, which are less than 2 centimeters. And how is ER therapeutic? It is therapeutic because for very small, it can be used for the resection of very small lesions. Again, very early stage, very small lesions. It can be fully removed. And after removal by endoscopic resection, if the histopathology reveals a well-differentiated carcinoma, limited to the submucosa, no LVSI, and clear margins, then it is therapeutic. Nothing needs to be done after that. So endoscopic resection is both diagnostic and therapeutic. And mind you, for early stage small tumors less than 2 centimeters. So what are the other radiological staging systems? One is the CT scan, just as I said. So how does it help? It provides the local mediastinal invasion. It tells us about the tracheobronchial invasion. Regional lymph nodes can also be seen, can be diagnosed. And how does it diagnose? Based on the maximal diameter, nodes larger than 10 millimeter are generally considered metastatic. MRI, just as I said, MRI in esophageal carcinoma has not been used routinely, neither has it been recommended, because it is not found to be better than the CT scan. PET scan, what about PET scan? It detects significantly more distant metastasis compared to the CT scan. It is 84% versus 63% accuracy. So if we have the PET CT scan facility available, then probably the PET CT scan would be a better way to diagnose metastasis. So now coming to the esophageal cancer staging. So staging, just as I said, EUS can be used. So just going into the brief anatomy. So there are the different muscle layer. You can see the longitudinal muscles, the circular muscles, the connective tissue in between them. Then comes the submucosa and the mucosa, and between them is the muscularis propria. So we generally use the TNM classification, which was revised in 1987. T stands for the tumor depth of invasion, N stands for the regional lymph node metastasis, and M stands for distant organ metastasis. So I'm not going to go into so much detail of the TNM staging, but T1, T2, T3 is important. So if you can see this, so there is something called the TIS. This is a high-grade dysplasia. HGD. So TIS is a high-grade dysplasia. Next comes the T1. You can see it in the image. So it is the tumor invades the lamina propria, muscularis mucosa, or submucosa. Then it is a T1. Now T1A, it is the tumor invades the lamina propria or the muscularis mucosa. You can see here the T1A and T1B. T1B is when it invades the submucosa. And what is T2? T2 is when the tumor invades the muscularis propria. And T3 is when it invades the adventitia. T4 invades the adjacent structures. In this, again, it is T4A and T4B. T4A invades the pleura, pericardium, azygos vein, diaphragm, and peritoneum. And T4B, it invades the other adjacent structures like the aorta, vertebral body, and trachea. So similarly, there are the N0, N1, and the N2 stage, and M0 and M1 stage. For our treatment, the T stage is very, very important. Of course, the nodal stage as well. So all esophageal tumors with epicenters within 5 centimeters of the esophagogastric junction that also extend into the esophagus are staged according to the EYCC esophageal scheme. There are various other staging systems as well. I'll come to the next one also. Tumors with an epicenter in the stomach that are more than 5 centimeters from the esophagogastric junction, or those within 5 centimeters of the esophagogastric junctions without extension into the esophagus, may be staged as gastric carcinoma in these cases. Like I said, the Siewert classification is very, very important for the adenocarcinoma patients. So all adenocarcinoma patients, especially those involving the esophagogastric junction, they should be classified right in the beginning, whether they are Siewert type 1, type 2, or type 3. What is type 1? Here, the adenocarcinoma of the lower esophagus with the epicenter located within 1 centimeter to 5 centimeters above the anatomical EJG. Type 2 is when the true carcinoma of the cardia with the tumor epicenter is within 1 centimeter above and 2 centimeters below the junction. And what is type 3? It is the subcardial carcinoma with the tumor epicenter between 2 centimeters and 5 centimeters below the esophagogastric junction, which infiltrates the esophagogastric junction and the lower esophagus from below. So these are the 3 types of classification of the adenocarcinomas. Now, the treatment approach, when we talk of the treatment approach, it basically depends on the stage, that is whether it is locoregional, that is 1, 2, 3, versus the metastatic stage or the stage 4. It also depends on the histological subtype, whether it is a squamous cell carcinoma or whether it is an adenocarcinoma. So you can see here, we have already seen this again before. Esophageal carcinoma T1 invades the submucosa, T2 invades the muscularis, T3 invades the adventitia, and T4 invades the adjacent structures. So this is just to make us remember these. And the similar things, you can see on the EUS also very, very clearly. So you can see here the scope inside, and this is the T1 tumor. This is a T2 tumor, which is dark, and T3 tumor, again, you can see this is dark, which has invaded the adventitia, and the T4 tumor, which has invaded the adjacent structures. Now coming to the treatment. Now high-grade dysplasia or T1A tumors less than or equal to 2 centimeter. Now these are very, very early stage diseases. This could be curable. So how do we treat them? Like I said before, endoscopic therapy, that is endoscopic mucosal resection, endoscopic submucosal dissection, and or ablation, these are preferred. You don't need to go for radiation. One does not need to go for esophagectomy. So an endoscopic resection is a very good treatment. Ablation alone is a primary treatment option for high-grade dysplasia or TIS. Ablation of the residual Barrett esophagus should follow endoscopic resection. So after the endoscopic resection has been done, if there is a residual Barrett's esophagus or a residual disease, then the ablation should be following the endoscopic resection. Now, this type of additional ablation may also be needed after endoscopic resection if we find a multifocal high-grade dysplasia present elsewhere in the esophagus. Esophagus is a very common site of skip metastasis or skip lesions or multifocal lesions. Extensive high-grade dysplasia or T1A adenocarcinoma with a nodular disease not adequately controlled by ER or T1B or deeper may be treated by esophagectomy. So whenever these are some tumors like the high-grade dysplasia or T1A or T1B, if after endoscopic resection, the physician sees that there is a nodular component to it, there is some residual even after endoscopic resection, and ablation is not the right treatment for this, then these are the cases where esophagectomy is a treatment to be offered to the patient. So coming to squamous cell carcinomas, T1B above, node plus, and locally advanced, resectable, and any nodes. So these are the locally advanced group of squamous cell carcinoma. Preoperative chemoradiation is the standard treatment for all these cancers. So except the non-cervical esophagus tumors, because the surgery for non-cervical, for the cervical carcinoma esophagus, it is not the preoperative, it is a definitive chemoradiation, because the cervical esophagus tumors, surgery is a very morbid surgery. So there is no question of preoperative chemoradiation for cervical esophagus tumor. So for cervical esophagus tumor, it is definitive chemoradiation. And I would like to mention here, for the cervical esophagus tumors, for radiation oncologists, they are better treated as head neck carcinomas. That is, the radiation dose is higher than the non-cervical esophagus carcinomas. Esophagectomy for non-cervical, again, esophageal tumors, T1B, CT2, N0, they can be an option. It is not only the preoperative chemoradiation is the standard treatment, but yes, esophagectomy may be done for such tumors if they are low-risk lesions, that is, well-differentiated and less than 3 centimeters. At some places, they mention it as less than 2 centimeter as well. So summing up, squamous cell carcinomas, locally advanced preoperative chemoradiation for non-cervical esophageal tumor, followed by surgery, definitive chemoradiation for cervical esophageal tumor, and esophagectomy can also be a choice for such tumors which are low risk, less than 3 centimeter, and well differentiated. Now, what about adenocarcinomas? For adenocarcinomas, which are locally advanced resectable, that is T2, T4A, any regional lymph nodes, preoperative chemoradiation is still preferred. Definitive chemoradiation is indicated only for T4B and non-surgical patients. Esophagectomy is an option for patients with low risk, less than 3 centimeter, well-differentiated tumors. So this is the CROSS trial, which has been actually the landmark trial and which has actually made a tremendous change in the way we treat locally advanced esophageal carcinoma. So very 2-3 lines regarding this, because this is a very, very important trial. So in this trial, locally advanced T1, N1, T2, N3 with any end tumor stages were included, both esophageal and esophagogastric junction tumors. Surgery alone, there were 2 arms, surgery alone or weekly carboplatin and with concurrent radiation therapy, followed by surgery. The radiation therapy dose over here was 41.4 grays in 23 fractions, and the chemotherapy agents were paclitaxel and cisplatin. The median overall survival with chemoradiation therapy followed by surgery was far better, that is 49.4 months versus 24 months. And hence this became a standard landmark trial. Now, about surgery, what are the indications or contraindications? Indications, yes, esophageal cancer in a patient who is definitely a candidate for surgery, who is fit for surgery. High-grade dysplasia in a patient with Barrett's esophagus that cannot be adequately treated endoscopically. So these are basically can be taken up for surgery. Contraindications, metastasis to N2 nodes, that is supraclavicular cervical nodes, or a solid, that is metastatic disease, or treatment of patients with celiac lymph nodes, involvement whether remains controversial. So metastasis to N2 nodes, it is a perfect contraindication for surgery. Invasion of adjacent structures, of course, these are also deemed contraindications for surgery. Now coming to the post-operative treatment, that is, a patient has come who has been operated. So probably this patient has received preoperative chemoradiation followed by surgery. And many times we do see patients who have come up with surgery upfront without any chemoradiation given preoperatively. So how do we manage such patients? So adenocarcinoma with no preoperative treatment and R0 resections, all TIS, that is the high-grade dysplasias, T3, T4 tumors, node positive T1, T2 tumors, and selected patients with T2 and 0 tumors, post-operative CTRT can be given, or as NCCN says, they should be given. So this is for adenocarcinoma. So you can understand, even for R0 resections, CTRT is given. This is absolutely in contrary to squamous cell carcinomas, where R0 resection post-radiation chemotherapy is not done. Now, chemotherapy following R0 resection in adenocarcinomas is indicated for all patients with adenocarcinoma, irrespective of the nodal status. Chemoradiation may be offered to all patients with residual disease who have not been treated with preoperative chemoradiation. Now, what about squamous cell carcinoma? R0 with it requires no post-operative treatment, even if a preoperative chemoradiation has been given. R1, R2, observation, or if there is an R2 palliative management, there is nothing you can do. Nivolumab is being given for R0 resections post-chemoradiation. So this is category 1 for YPP positive and N positive. Now, what about those patients who have not received preoperative chemoradiation? If there is an R0 resection, no postoperative treatment is indicated. And if there is an R1, R2 resection, then chemoradiation may be given or may be palliative. So these are the general guidelines. I wouldn't say guidelines, they are generally the approaches to such patients who come with esophageal carcinomas after surgery. Now, what is the role of chemotherapy? I'm not going to talk much about chemotherapy because I'm not a medical oncologist, but fluoropyridine-based or taxane-based regimens are indicated for preoperative and definitive chemoradiation. Trastuzumab plus first-line chemotherapy for HER2 overexpression in advanced and metastatic adenocarcinomas have been given. And ramucirumab, either as a single agent or in combination with paclitaxel, was approved and has been tried. And there are various chemotherapy protocols. And nowadays we also have we go ahead with the HER2 receptors and we do I'm just coming to that. So this is the treatment algorithms. All this time I was talking mostly about what the NCCN guidelines they show. But there are ESMO guidelines also, but fairly the same. So you can see here, after the endoscopic staging, initial staging, early disease, they have advised for resection. And if they're locally advanced and squamous cell carcinoma, in squamous cell carcinoma, again, they go for non-neoadjuvant CTRT and definitive CTRT. And if there is a good response, then salvage resection, then follow-up. Otherwise, salvage resection is done and adjuvant nivolumab is given. So you can go through this protocol. It is available everywhere, and these are recent 2022 ESMO algorithms. So this was the last slide. So any questions or anywhere I need to go over once again?
Thank you, Dr. Swaroopa. It's a very nice presentation, very clear-cut view regarding surgery and diagnostic part of the carcinoma esophagus. From the audience, if somebody has any question, please, you can ask the question. So this is a very nice rock. Early lesions can be diagnosed by endoscopic ultrasound, and the depth of invasion can be very well assessed, better than CT scans, as Dr. Mitra has told. And endoscopic resection is the choice for the early lesions, and that can be cured. So provided the lesion is less than 2 centimeters. MRI, of course, it may help, but not better than CT scan. And best is the endoscopic. You can go ahead with the chemoradiation, is the standard trial for the advanced stages. As she has shown, cross trial, which is a very famous trial, where carboplatin plus paclitaxel was used along with the radiation, 40 to 42 grays. And then the patient were subjected to surgery. And they have shown better survival and better life. So these are the few things which are very important. And early diagnosis is always there, and that takes the advantage, and patient can have a better life and disease-free life after getting this. So any other question from the audience?
I would like to support the view of early diagnosis, because in 1950s, it is mentioned that only 5% survive. Now, because of the technology, it has reached to 20% in 4th stage. The 4th stage also is very good. Any other questions? Kindly unmute all.
Actually, in earlier days, endoscope was not available. I'm talking about the era of 1980s, where endoscope was not available. So it was only the X-ray, barium swallow. On that ground, we were able to diagnose whether it is carcinoma esophagus or what. So they were treated without even histopathological diagnosis, because we were not having any means to take out the tissue for diagnosis. Later on, when we came up with the endoscope, earlier we used to have rigid endoscope at few centers, and then we have come out with the Olympus endoscope, and we started using biopsies, and then started treating the patients. So this was the status in earlier stages, earlier years.
The question in the box.
Okay.
Check. Check. Last.
There was a question in the chat. Which patient we can give NACT? Dr. Mitra?
Yes. So it is very clear. All locally advanced cancer patients,
Correct.
B onwards, any N, it is the method of choice is NACT followed by surgery, except the cervical esophagus.
Correct. Any other question?
Why not cervical esophagus?
Because ma'am, the cervical esophagus, the surgery is very morbid. So it is treated, yes, so it is treated as a head neck carcinoma with CTRT itself, not preoperative, definitive CTRT, and the dose is also higher than the esophageal carcinoma dose. It is similar, like in esophagus, we give about 45 grays, and if you are not giving, maybe 45 to 50 grays, but in cervical esophagus, we go up to 66 to 70 grays.
Easily.
Okay. Nice. Thank you so much. Thanks for the beautiful talk and beautiful narration, good slide presentation. And thanks all for patient listening and being a wonderful audience. Thanks to the technical team and all our viewers.
Thank
So-
Dr. Swaroopa Mitra for such a clear talk and very concise, in a very concise form. It's
Thanks
a very
a lot.
nice talk.
Mhm.
Thank you very much for
Beautiful.
sparing some time for
Yeah.
our group.
And for
And,
Always my
accepting it.
privilege. So always my privilege.
Okay, next
Thank
time
you.
we meet again. Maybe
Yes,
some
yes,
other
ma'am.
Saturday. Let's see.
Yes, ma'am. Yes,
We'll plan it.
definitely.
Okay,
Okay,
so
thank
nice
you.
of you for accepting this. And thank you. It's an honor and privilege. Thank you.